Okay, so we're going to wrap up our look at the digestive system with common pathologies. Just a few more combining forms here. Lepero, referring to abdomen, as well as abdomino, we know refers to abdomen as well. So being mindful of multiple combining forms for the same general meaning. We've seen some of these too with overlap with the respiratory system, right? Such as with the pharynx. We know that that is a shared structure between the respiratory and digestive system, as it carries food to the digestive tract, and it also carries or is a passageway for air through the airways. So let's look at pathologies. We're going to start with GERD, or gastroesophageal reflux disease. So GERD involves the lower esophageal sphincter not fully closing. So this sphincter is at the bottom of the esophagus and to the opening of the stomach. Now, if it either is not operating properly and so it does not fully close, or in some cases that tissue becomes damaged, contents of the stomach will then travel back up into the esophagus. And this backwash of stomach acid, also referred to as acid reflux, eventually irritates the lining of the esophagus. The stomach is built to really be able to withstand the significant acidity of stomach acid, which contains hydrochloric acid. The esophagus is not quite built in the same manner, does not have as thick of a muscle wall or as protective of a mucosa or mucus lining as the stomach does. And therefore, the acid is more damaging to the esophagus if it makes contact with the lining of the esophagus. This causes that burning sensation, chest pain, and in severe cases, and especially if there becomes damage to the esophageal lining, there can be difficulty swallowing or pain with swallowing. Ulcers are sores that develop in the lining of the stomach. So if that mucus lining or the mucosa of the stomach becomes damaged, then erosions of the stomach lining occur. And these erosions can heal on their own, but deeper and larger erosions of the stomach lining become ulcers. And again, this is if the mucosa is broken down. There are multiple causes of this. Certain medications, such as NSAIDs, or non-steroidal anti-inflammatory drugs like Advil or naproxen, for example. These particular medications are very hard on the lining of the stomach, and that's based on the way that they are absorbed into the body and into the bloodstream. They're very erosive to the gastrointestinal lining. And so these medications, if taken frequently or in large quantities, can lead to the erosion of the lining of the stomach. Also infections. So infections such as that by Helicobacter pylori can contribute to ulcer formation. So if there is an overgrowth of this particular type of bacteria within the stomach, it can eventually lead to, again, breaking down of the stomach mucosa. Now, if the mucus that lines the interior of the stomach becomes worn away, now the stomach lining is more susceptible to the acid within the stomach. That acid begins to, again, erode away the stomach lining. And H. pylori, for short of Helicobacter pylori, can contribute to this wearing away of the lining and therefore the formation of ulcers. In severe cases, ulcers can be associated with bleeding of the stomach. And so if there is a bleed within the stomach or in a region of the digestive system, then this can be observed through blood in the stool. And that can be an indication of a bleed. Now, many of us can probably identify someone that they know who does not eat gluten or has a gluten-free diet. And certainly those with celiac disease are gluten-free. Celiac disease is an immune sensitivity reaction that occurs in the small intestine, specifically in response to gluten. So what happens is, if we take a look at the lining of the small intestine here, in a normal individual, the small intestine is lined with cells that contain villi. And these villi are these small hair-like projections which serve to increase the surface area of the small intestine. So having just a flat surface versus having many small projections, these projections have a surface area of their own, and this increases the overall cumulative surface area of the small intestine. Increasing the surface area of the small intestine is beneficial because an increased surface area means that there is a higher absorptive capacity of the stomach. So there is a greater surface region where absorption of nutrients can occur from the contents of the small intestine and into the bloodstream. So these villi help with that. Now, in an individual with celiac disease, the villi become damaged. And so we can see here that the villi are no longer in this, slim projected appearance, but we see some inflammation. And again, this is a autoimmune or immune sensitivity reaction. And gluten in particular and the proteins within gluten trigger this response in the small intestine. Consider the trigger a little bit more. Gluten is a protein that is found in grains like wheat, barley, rye. Most people can digest gluten easily. But with celiac disease, the body treats a specific part of the gluten protein called gliadin like it is a foreign invader such as a virus or bacteria. And this is where the immune involvement comes in. So when gluten enters the small intestine, the immune system mistakes it as being a foreign invader. So it sees the gluten protein and it sends out white blood cells and inflammatory signals to attack the gluten. And in this process, the immune system also attacks the healthy lining of the small intestine. And so in response to gluten making contact with the small intestine, the body triggers an immune response that causes the destruction of the villi. And that's why they gain this appearance in response to eating gluten if someone has celiac disease. So the target becomes the villi. And now the small intestine goes from having these small projections to sort of warped bumps that are not able to sufficiently increase the surface area of the stomach. So they shrink and eventually they become flat. And so over time they get more and more flattened. And this reduces that function of the small intestine, which is to have the increased surface area for absorption. So over time, as the villi get destroyed, food just slides right over them. And it doesn't matter how healthy an individual eats, if these villi are destroyed, the body can't absorb the nutrients that it requires. And it leads to malabsorption or bad absorption through the small intestine. So again, at its core, celiac disease is an immune sensitivity or an autoimmune disorder where the body ends up attacking the villi of the small intestine in response to consuming gluten. So gluten triggers this immune response. Now we're still going to focus on the intestines, but now we're moving on to the large intestine. So something to note and pay attention to, as we saw with the stomach, for example, if we think about the normal functions of these structures, and we then think about what might happen if these normal structures aren't behaving or performing the roles that they should. This is how and where we characterize disease states. So now if we think about the large intestine, we know that the large intestine is largely responsible for moving food along, forming feces, water absorption, and eventual elimination from the body. So let's talk about diverticulosis. And if you look at the slide here, you can see small grape-like pouches, really, bulging out from the wall of the colon. And these are called diverticula. So we can see one highlighted here, bulging out of the wall of the colon. When a person has many of these pouches, this is a condition called diverticulosis. And these pouches come about because of pressure within the colon. So think of the colon as a hose. And if an individual has a diet that's really low in fiber, your stool becomes very small and hard. The colon has to work much harder to move that stool along to eliminate it from the body. And chronic constipation like this creates high pressure against the inner walls of the digestive tract. There are specific spots in the colon where if the internal pressure gets too high, the inner lining of the colon gets pushed out through weak spots that are in the muscle. And the lining bubbles out, forming a diverticula. They often occur in the sigmoid colon, which is the lower region of the colon here that connects with the rectum. And this is because the sigmoid is the narrowest part of the colon. And the narrower the tube, the higher the pressure that's required to push things through it. Now, most people with diverticulosis don't even know they have it. However, if a piece of hard stool or significant bacterial growth gets trapped inside one of these pockets or pouches, it can cause an infection and inflammation. And that is when it turns into diverticulitis, ending in itis for inflammation, and this can lead to fever, pain, or even rupture. This can require hospitalization and IV antibiotic requirements. So to summarize, again, high pressure inside of the colon, often from a diet that's really low in fiber, can lead to the formation of diverticula, or these pouches that push through weak spots in the muscle wall of the colon. The result is these permanent pouches that may contain food that becomes stuck over time and bacterial overgrowth, which can lead to diverticulitis. So when we look at the lower respiratory tract further, we can now see that we categorize diseases by what we can see. So we've seen structural diseases like diverticulosis, and we've also seen some structural disorders like celiac disease leading to the destruction of the villi. And we can see other structural diseases, including IBD, so inflammatory bowel disease, and other functional disorders like IBS or irritable bowel syndrome. Now, inflammatory bowel disease is a serious autoimmune condition. So similar to celiac, this is an autoimmune condition where the body's own immune system attacks the gut. And in this case, it causes visible inflammation and raw sores within the digestive tract. So the digestive tract becomes really inflamed with raw sores. And there are two common types of IBD. This includes Crohn's disease, and it can occur really anywhere in the digestive tract from the mouth to the anus, but it usually occurs in the upper GI tract. It attacks the entire thickness of the wall of the alimentary canal. And it's often patchy. So you'll see a diseased area, then a healthy area, then another diseased area. So again, this includes visible inflammation and raw sores. Another type is ulcerative colitis, and this is specific to the colon and rectum. So unlike Crohn's, it only attacks the inner lining as well of the colon and rectum, and it starts at the bottom and moves up. So there's no spaced out patchy diseased areas like you see with Crohn's disease. Now, these are chronic conditions. They can be treated, so the symptoms can be managed and treated, but they cannot be cured. So individuals may experience flare-ups of these autoimmune disorders, where they may require hospitalization and further treatment, but these are lifelong conditions that are associated with this chronic inflammation of the digestive tract. Now, it can kind of flare up in bouts, and so in response to particular dietary choices, in response to stress, these events can trigger a Crohn's flare, for example, where an individual might need to be hospitalized because the condition has temporarily worsened. So it can't be cured, but it can be managed. Now, irritable bowel syndrome, or IBS, is often confused with IBD, but they're very different. So IBS actually has an unknown cause. So if someone did a colonoscopy, for example, on an IBS patient, the tissue would actually look pretty healthy. No ulcers like we see in IBD, no pouches like in diverticulitis. However, the patient experiences bloating, gas, abdominal pain, and it's believed to be a problem with how the brain and the gut communicate. So the nerves become oversensitive, making the muscles within the gut move too fast or contract too much or too slow. But because there's no physical damage, we treat this through dietary and lifestyle changes. So this might be associated with increased constipation or frequent diarrhea, but there really is no specific known cause of IBS, though we do know that certain foods can be more challenging on the gut and lead to increased irritability of the bowels. So IBD and IBS, even though they are thought of as being similar, IBD is referring to an autoimmune disorder, which could be Crohn's or ulcerative colitis, those two being the most common types associated with inflammation or sores in the digestive tract. Whereas irritable bowel syndrome, there is really no specific pinpointed cause or physiological observation in particular, other than bloating, gas, abdominal pain, diarrhea, and can be managed with dietary and lifestyle changes. So let's look at another structural abnormality that can occur in the abdomen or even in the groin area, and that is hernias. So while our previous topic, diverticulosis, involved pockets forming inside the gut wall, a hernia is a more global structural issue. So a hernia occurs when fatty tissue, usually a loop of the small intestine, so a particular region, actually pushes through a weak area of muscle or connective tissue. So think of the abdominal wall, basically like a pressurized vessel. Think of it like a car tire, and it's meant to hold all your internal organs in place under pressure. However, if there's a thin or weak spot in that muscle and internal pressure increases, so lifting, coughing, straining, the structures within the connective tissue or muscle take the path of least resistance. And what happens is when the pressure increases, they herniate or they bulge out through the gap or the weak spot. So think of it like a tire essentially popping, and there's a weak region of it where something would be most likely to escape from or where air would leak first. So with a hernia, there's a weak spot in the muscle that's overlaying the abdomen, and a region of the intestines essentially bulges through that weakened muscle area. So if you look at this diagram here, you can see the large intestine, and this section here labeled abnormal contraction. So it illustrates how internal gut pressure and movement play a role. So when the pressure becomes too great for the surrounding muscle to contain, we see the physical protrusion of the essentially intestine through the muscle lining of the abdomen. This often manifests as localized pain, a visible bulge. While the slide does mention abdominal pain, diarrhea, and constipation, these are often secondary to the disruption of normal gut motility that occurs because the tissue is being out of its proper place. And there's the displacement of this tissue through the muscular wall of the abdomen. So before we go into disorders of the accessory structures, we're going to wrap up talking about the colon with some growths that may occur in the colon. So this slide basically reinforces the importance of colonoscopies. So colonoscopies are recommended after an individual, I believe in Canada, turns 50, if there is a genetic predisposition to polyps or the formation of growths in the colon, then an individual might be encouraged to go for a colonoscopy at an earlier age. But a colonoscopy may take photos like the one taken here, where a camera is inserted through the anus and through the colon, and the intestine is viewed. And this is where you might be able to visualize an abnormal growth within the intestine. So polyps, I'm going to start with polyps here. So polyps are small growths that protrude inward from the intestinal wall and into the lumen of the intestine, or the space where food passes. So they're typically found in patients over 50, and that's why it's around that age where a colonoscopy is recommended. And while many are benign, they can become cancerous over time. And so this is why screening colonoscopies are so important, because we want to remove the polyps before they can transform into cancer. So colon cancer is one of the most malignant types of cancer. And we can see here these stages of growth, right? So stage 1 is where the polyp stays, or the cancer stays, in the inner layers. But by stage 4, the cancer has pushed through the muscle and spread even to other organs. So we can see it's pushing up. It has gained a blood supply, or angiogenesis, here as well. So now the tumor is receiving nutrients, and this is promoting its growth, and it may travel into a nearby lymph node to travel to other locations in the body. So there are certain risk factors that increase a patient's chances of developing this malignancy, or the progression of a polyp into a cancerous tumor. This includes smoking and alcohol intake are directly associated with an increased risk of colon cancer. A diet that's high in nitrates. So nitrates found in cured meats are actually associated with a significantly increased risk of developing colon cancer. And also diets high in animal fats are associated with an increased risk. As I mentioned, a family history, so genetics play a very big role in the development of polyps and also colon cancer. Common symptoms include constipation, diarrhea, cramping, and in more severe or even in cancerous stages, abdominal pain and bleeding from the rectum. Again, most polyps are benign, and that's why screening is so important, but some are or can become, especially over time, cancerous. So this is why screening, whether it's, as we talked about with the skin, screening for skin cancer of moles, and also screening through colonoscopies of growths in the colon is really important. So now we're going to move into the accessory structures, and we're going to wrap up here with the gallbladder and the liver and disorders associated with them. Now, for those of you watching this video, and I would typically ask this in a classroom, but I would say, who doesn't have a gallbladder? And typically there are a few individuals who have had their gallbladder removed. Now, the gallbladder might need to be removed for various reasons. So let's first look at cholelithiasis. Chola, we know, also means bile, and lithiasis means stones forming. To best understand pathology, if we break down the word, we can understand what it's referring to, right? So collectively, we simply know these as gallstones. Now, these stones can range in size from being a tiny grain of rice to as large as a golf ball. And while small stones might pass from the gallbladder through the cystic duct, which carries bile from the gallbladder into the small intestine, large stones, and especially as they increase in size, are more likely to block the bile duct. When a blockage forms in the bile duct that carries bile again from gallbladder, it travels through this portion called the cystic duct, and it joins with the common bile duct, which drains that bile into the small intestine. So if a blockage occurs in the common bile duct, the patient will experience significant pain, discomfort, inflammation, and swelling or increased size of the gallbladder because the bile doesn't have anywhere to go and it becomes trapped in the gallbladder. Now, if that blockage isn't cleared, that's when we move into cholecystitis. So inflammation of the gallbladder, and cholecystitis is usually a direct result of those gallstones. So when a stone develops that physically blocks the bile duct, the bile is trapped, the backup makes the gallbladder irritated, swollen, and eventually inflamed. Now, I want to compare diverticulosis with gallstones. Now, in the colon, we saw physical pouches, those diverticula, that trap food and become inflamed, becoming diverticulitis. In the gallbladder, we see physical stones now that essentially trap bile within the gallbladder, leading to inflammation, cholecystitis. So in both of these aspects of the systems here, the pathobiology is the same, right? A mechanical obstruction leads to an inflammatory response. So there are many instances in the body or in various systems of the body where there is some kind of mechanical obstruction or a blockage that leads to increased inflammation. Now let's move on to the liver, one of the most vital organs in our body for detoxification and metabolism. And while the liver is famous for its ability to regenerate, which many of you may know that if a portion of the liver is removed or damaged, it can regenerate, it still has its limits. And today we're going to look at what happens essentially when that damage is significant, or when the limit of regeneration, if you will, is reached. So I'm going to start with hepatitis. Now, the word hepatitis literally means inflammation of the liver. This is the liver's initial response to damage. So think of a red, swollen alarm state. And as we can see, the inflammation can be triggered by several factors: alcohol consumption, toxins and medications, because the liver is responsible for filtering the blood after it leaves the small intestine. So as I mentioned, after nutrients or anything that you consume is absorbed from the intestines and into the bloodstream, it travels through the hepatic portal vein to the liver. And in the liver, that blood is filtered. So this includes alcohol that is consumed, toxins and medications. So Any medications that you ingest eventually enter the bloodstream and are filtered by the liver. And therefore, depending on what is consumed and what the liver is filtering over time, a accumulation or an overload of the filtering capacity of the liver may occur, and an overconsumption of alcohol and toxins and medications or even other drug use can be associated with inflammation or damage to the liver and hepatitis. Immune responses or autoimmune responses can also result in hepatitis. So essentially autoimmune conditions where the body is producing antibodies that end up damaging its own tissues, such as in the liver. So if the inflammation is caught during the hepatitis phase, the damage can perhaps be stopped. But if inflammation continues for years and there is repeated stress put on the liver, it can lead to cirrhosis. Cirrhosis is the scarring phase. And so when the liver is constantly inflamed or under stress, it eventually stops trying to heal with healthy cells and essentially starts healing with scar tissue instead of the healthy regeneration. And the formation of scar tissue due to prolonged constant inflammation is cirrhosis. So if we look at this comparison here, we can see that the liver with cirrhosis is bumpy, shriveled, and it's covered in scar tissue. So unlike hepatitis, cirrhosis is a chronic condition that cannot be cured. So the healthy liver tissue is physically replaced by this hard fibrous tissue. It can't filter blood as well, and this is why it can become life-threatening as it progresses. So the buildup of toxins in your blood and in the body occurs because the liver is not performing its function. Again, when we think about pathology, we think about the typical function of that structure, which in the case of the liver is to filter our blood, filter the body of toxins, medications. And if there is damage to that structure, it can no longer perform its typical functions. And this will cause negative outcomes such as toxin buildup and damage to the actual tissue of the liver itself. So this slide highlights that chronic alcoholism and long-term liver diseases such as untreated hepatitis C, for example, are the leading causes of this transition from inflammation to scarring of the liver. Now, over time, symptoms may present that indicate underlying issues with particular structures, such as with the liver. And one of those is jaundice. So jaundice is not a disease itself, but it's a symptom of an underlying issue with the liver or even the gallbladder or the blood. So it's characterized by a yellowing of the skin and also a yellowing of the whites of the eyes or the sclera of the eyes. The yellow coloring comes from a substance called bilirubin. So bilirubin is a yellowish pigment that is created when the body breaks down old red blood cells. So red blood cells have a lifespan of about 120 days. And as blood cells become worn out, they don't perform their function of carrying oxygen or binding hemoglobin as efficiently. They need to be broken down. And this occurs in the liver. So normally, bilirubin is produced when the body breaks down old red blood cells, and the liver collects this bilirubin from the blood, processes it, and sends it to the gallbladder to be stored as part of bile. Eventually, it's excreted through your stool. So as you produce bile that is sent into the intestine, that bile and bilirubin with it is excreted through the stool. And this is actually what gives stool its brown color. But if the essentially bilirubin is building up in the blood because it has nowhere else to go, this leads to jaundice, or this appearance of the yellow coloring. And there are three main ways that this can happen. Again, so red blood cells, when they are broken down, the spleen is also involved in the breakdown of red blood cells, but bilirubin is going to be collected by the liver, processed, and then sent to the gallbladder, where the gallbladder eventually excretes it into the stool. So if there is liver failure, such as conditions like hepatitis with inflammation or cirrhosis with scarring, these conditions damage the liver cells. If the liver is too scarred or inflamed, it can't process that bilirubin or remove it from the blood. Therefore, the pigment stays in the bloodstream and eventually leaks into the skin, causing this yellowing. And connecting with the functions of the gallbladder, so if gallstones block the bile duct, now that bile, which contains bilirubin, can't get out. So it backs up into the liver and then overflows back into the blood. And this also leads to the observation of jaundice. And finally, if red blood cells are being destroyed faster than the liver can keep up with, the system gets overwhelmed with too much bilirubin. So in a pathophysiology setting, you consider three main things. So there's the yellowing of the skin and eyes, dark urine, because the kidneys will eventually try to help by filtering the excess bilirubin, and pale stool. So if the bilirubin is blocked, it never reaches the intestines, such as if there was a blockage caused by a gallstone. So the stool loses its brown color because that bilirubin is no longer being excreted through the stool. So jaundice is this symptom of these other disordered states that are occurring, whether it's from liver failure or gallbladder obstruction due to a gallstone, or essentially excessive breakdown of red blood cells from other conditions like anemia or infections. So we see these connections, right, between structures and the pathology within the digestive system. So we can consider how the functions of each of these structures contributes to the pathological states that we observe. And the loss of function of the structures is associated with various disease states. So to kind of summarize and look back at what we discussed in this lecture, looking at the nervous system, we discussed the structures of the nervous system, and we looked at disorders of the nervous system that are associated with acute traumas, so things like concussions, also things like TIAs or stroke, and then we looked at more degenerative diseases such as Alzheimer's, glaucoma. We also looked at degenerative diseases such as progressive diseases like multiple sclerosis and Parkinson's. So we saw diseases that are more sudden or acute, and also things that develop over time. With the digestive system, we reviewed the structural anatomy, and then we walked through each basically level of the alimentary canal. So we looked at upper respiratory tract disorders involving the esophagus and damage to the stomach. We looked at some autoimmune conditions, such as immune sensitivities associated with celiac or autoimmune disorders involving IBD. And we also looked at some structural abnormalities like hernias, growths that can occur in the colon, and disorders associated with the accessory structures. So the key here with this particular slide deck, again, is considering the structure, considering the terminology involved. So are we talking about inflammation of that structure? Or are we talking about a condition or disordered state of a given structure? And that informs us of the specific pathology that we're talking about. So if you have any questions about this unit, feel free to reach out. You can email me if you have any questions about the quiz as well. So take care, and I will see you next week.